You like kind of look at yourself in the mirror and you're like, okay, my biceps actually do look a little bit bigger. Let's talk a little bit about what TMS is. It's a non-invasive brain stimulation technique that kind of feels like somebody is hitting a funny bone within your brain. TMS activates neurons more directly through electricity. PBM kind of energizes them biologically from the inside outwards. We're seeing early and promising data that PBM can modulate cortical excitability, and when it's paired with TMS, the two may amplify one another's effects. Multiple interventions can actually be what produces the best results and really makes differences in clients' lives.
So welcome everyone. I'll introduce our speaker. So today we're excited to welcome Alyssa Igarta today. She will explore how transcranial photobiomodulation and transcranial magnetic stimulation can be used together to enhance brain function and therapeutic outcomes. So Alyssa holds a bachelor's degree in psychology from the University of British Columbia and is pursuing her master's in counseling psychology at Yorkville University. She's worked in neuromodulation for several years, previously leading a TMS program in a neurofeedback clinic. And now she's supporting operations and customer care at Neuronic. And her presentation will be about 30 to 45 minutes and followed by Q&A, but feel free to ask any questions along the way in the chat or raise your hands, and especially if you need any clarification on the slides. So I'll hand it over to Alyssa now to begin the presentation.
Thank you for letting me present. I'll just run through a little bit more about myself. So my educational background has always been in the mental health field and psychology realm, hence the BA in psychology. A little bit more than neuroscience. Not that the two can't go hand in hand with each other. After completing my BA, I wanted to get some experience before just jumping right into a master's program. I didn't want to pursue a master's in something I wasn't really confident in. Psychology is such a broad field. There's so much that you can do with that. Kind of led me to my neuromodulation experience where I worked as a technician. This is actually where I discovered PBM because we were using it in clinic. We did things like neurostim, brain mapping, neurofeedback, and of course TMS, which is why we're here today. I don't really know why, but I was always drawn to the modality of TMS specifically. I did a lot of developing of protocols, looking into the research, meeting with clients, etc. And now that I'm almost done my master's in the counseling psychology, I'm still a team member here at Neuronic, helping mostly, as Brooke said, with customer operations and occasionally sometimes touching points with the research team. And so here is the evidence. I swear I did work as a TMS technician. No, the machine did not fix me, but it really works for other people. Alrighty, and as you can see too, this machine is a little bit different than the one that you saw on the previous slide. So let's talk a little bit about what TMS is. TMS, or Transcranial Magnetic Stimulation, which I'll be referring to as TMS as it's quite a mouthful. It's a non-invasive brain stimulation technique that uses magnetic fields to induce small electrical currents in the cortex. These currents directly stimulate neurons, which can influence neurotransmitter release and change activity within key brain networks. TMS typically affects tissues about 2 or 3 centimeters deep, so mainly cortical areas. Clinically, it's FDA approved for major depressive disorder, obsessive compulsive disorder, and smoking cessation, though there's a lot of evidence supporting its use for other modalities, and there's a lot of research and off-label protocols you can get into. It's really popularly used for PTSD, anxiety, tinnitus, though, again, those are off-label applications. And the appeal of TMS is that it's both targeted and non-invasive, and it has pretty minimal side effects generally. It is a little bit more intense when we're comparing it to PBM in the sense that, as somebody who's experienced it myself, you do feel it, and it can be a little bit jarring. I always describe it to clients that it feels like somebody is hitting a funny bone within your brain. So it feels a little bit weird and uncomfortable, but not necessarily painful. And this here is just a picture of what a typical machine would look like. We would call this a figure 8 coil because it looks like a figure 8. And so essentially the machine on this side, it's the same thing, just that coil would be inside of that helmet. So this is just a bit of a newer model and it looks just a little bit cleaner. It's more user-friendly. Whereas something like this, it's a bit more difficult. You have to hold the coil, which is very heavy, kind of position it around. It's just a little bit harder to use. And so let's talk about some side effects and contraindications. So, even though TMS is considered safe and well tolerated, it's important to recognize that there's contraindications and common side effects as well. We avoid TMS in individuals with anything like implanted metal above the shoulders, a history of seizures, or anything serious head trauma. So, implanted metal is self-explanatory there. If we're creating electrical impulses, that metal could heat up, and then that could cause damage to the surrounding tissues. But certain things, like if it's a jaw implant, things like that, or a lot of people have metal teeth, that's not so much of an issue in the skull area. Seizures, because it is quite intense and inducing electrical impulses, it's good to avoid it with people with a history of seizures, just because, of course, we don't want to induce anything. But this is always up to a doctor's discretion. If somebody had maybe one seizure when they were 3 years old, very different than somebody who's struggling with epilepsy. And then we also avoid serious head trauma. Again, it can just be very difficult to use on clients with serious head trauma. We'll get into the logistics of how TMS works, and it just doesn't really necessarily work with people with head trauma. And I'll touch on that a little bit later. And by serious head trauma, they were in a major car accident. I don't mean they had a concussion here or there, a serious major TBI. And so the most common side effects are pretty mild. So things like scalp discomfort, twitching, sometimes a headache. And this will especially be during treatment. Of course, if it's pulsing on your scalp, it's going to feel a little bit uncomfortable a lot of the time because if we're stimulating over the frontal area, sometimes the muscles in your face will get activated. So while you're doing the treatment, some people you'll see them, their eyebrows are going up and down, their jaw will clench a little bit. So those muscles just get activated and it looks a little funny, but as soon as the stimulation's done, it stops. And headache, again, as someone who's felt it, I can understand why people would get a headache from it. Again, it's a weird sensation. You're strapped into this big machine. Just looking at it sometimes gives me a headache. But again, these things don't really persist typically too much like after a session. Occasionally, some people will feel fatigue, dizziness, or even temporary tinnitus, but these are pretty short-lived. It's a pretty loud machine, so temporary ringing in the ears is normal. Fatigue and dizziness, we're doing a lot of brain stimulation. Of course, your brain's going to be a little bit tired afterwards, but these are not common. I would say, personally, in my experience, I've seen some side effects, but not everyone. I would say there was one or two people that would really experience the side effects to a point of discomfort or maybe not wanting to pursue the treatment. The most rare but most serious risk of TMS would be a seizure, though through a controlled setting, it's really uncommon, like less than 0.1%. If you're doing everything properly and safely, it's very minimally, it's not a really big risk. So for most patients, TMS, it's well tolerated and it doesn't really require any downtime. You can walk out of a session and immediately just go back to work, do your normal activities, things like that. You don't need to sit in the waiting room and wait to drive your car or anything like that. Again, it's pretty minimally invasive. You're in and you're out after. So before beginning TMS, we have to determine each person's motor threshold. Essentially, this is how easily their brain responds to stimulation. I sometimes refer to this as dose. This helps us determine what dose of TMS this person needs. Are they someone who's going to need quite a lot of stimulation to really activate their brain, or are they more sensitive? Do they just need a little bit less? So, essentially, what a motor threshold is, it's a measure of cortical excitability, which kind of helps us, again, individualize that treatment dose. The idea is that everybody's brain is a little bit different and has a different sensitivity to the magnetic fields. So we can calibrate the device to the minimum level that produces a measurable response, which is usually a twitch in the right hand. If we're looking at this picture here, what we would do is we would place it over the person's motor cortex and it would give you a response in your hand motor. So if we're activating the motor cortex, it goes hand in hand there, you're going to see a motor response. So the threshold's kind of a personal benchmark for treatment intensity, making sure the stimulation is comfortable with everyone. So how would we do this? Again, in this photo here, you can see it's placed a little bit further back over the motor cortex. So what we would do is we'd locate specifically the left motor cortex. So typically around, if you're familiar with the 1020 system, around the C3 area, and we would deliver single pulses until we observe movement in the right hand. So typically what we would do is we would start the intensity off very high, and you would see like their whole hand move or something crazy. And then you would lower the intensity until you see just it'll be the slightest like little twitch of the finger. So you have to be really vigilant looking, making sure it's at the same time as the pulse. If their finger's just twitching randomly, okay, it's probably not related to the TMS stimulation. So you try to get the lowest intensity that results in a very small motor response. Often in clinics, this is just measured visually, though some people will use something like an EMG to confirm and make it more accurate. Though day to day in a clinic, I'm not sure how feasible this is. Most clinics just confirm visually. The motor threshold can vary between individuals, even in the same like person across sessions. So what my motor threshold is on Tuesday is could be very different than what it is on Wednesday. There's a lot of things that can affect this, which again goes back to your cortical excitability. So things like sleep, caffeine intake, certain medications, anything that would affect your cortical excitability. And that's why we often test the motor threshold pretty regularly. It's not a one-time setting. You need to evaluate it quite often because it's a dynamic measure, and so it adapts as the brain responds to treatment as well. In practice, this looks like typically most people will do once a week or once a month. If it was up to me, I would honestly assess it every single day if the time parameters allowed that. Again, if you had a bad sleep, that can affect your motor threshold. And of course, some clinics will do it where they'll ask clients these things. And if clients did have a bad sleep or had a lot of caffeine, then they'll reassess. I just think there's so many things that can affect your motor threshold that clients are not even aware of and they might not even know to tell us. And I think there's even things that maybe we don't know affect the motor threshold still and the motor cortex. So good to keep in mind. So obviously this is a lot of information and it's quite complex. I would not explain TMS this way to clients. I find that sometimes it'll go in one ear and out the other. So I have a couple of little analogies that I would typically use when I'm speaking to people. So when I explain it to clients, I describe it this way. The most popular use for TMS is to treat depression. So typically in depression, parts of the brain, particularly our prefrontal cortex, are underactive. So it's like those regions have fallen asleep a little bit or a little bit sleepy. TMS is like that alarm clock, nudging those areas awake. So the motor threshold kind of sets the volume of that alarm. So if it's too quiet, we're not going to hear it. We're going to sleep through our alarms. If it's too loud, it's going to wake us up and stress us out, and we're going to be so scared. I know this happens to me when I set my alarm way too loud. I feel like, I don't know, I wake up thinking it's the end of the world or something. So we want it to be at that volume where it's going to wake us up, but it's not going to wake us up in a panic. So over time, as the brain relearns how to activate itself, it doesn't need the alarm as often. It'll start to regulate itself naturally. Again, if you notice yourself, if you have a very consistent sleep schedule, even on the weekends, maybe when you don't have an alarm set, you'll still wake up right around that time you normally do during the week. And so that's the idea here is that we want, quote unquote, the brain to start working, quote unquote, normally without needing this stimulation or this intervention to get it going. So now that we've looked at TMS in more detail, let's just take a moment and kind of compare it to photobiomodulation, because even though both are forms of neuromodulation, they work in very different ways. So the first part that they're a little bit different is their mechanisms of action. TMS works through a magnetic induction, where a magnetic coil sends rapid pulses through the skull, creating small electrical currents that make the neurons fire. Well, PBM, on the other hand, uses near infrared light. And so that light gets absorbed by your mitochondria, stimulating ATP, nitric oxide, and blood flow. So TMS activates neurons more directly through electricity, where PBM kind of energizes them biologically from the inside outwards. The second would be their level of target. So TMS mainly targets very specific cortical regions to modify neural circuits and connectivity. But PBM works more on the cellular and the vascular levels, supporting the metabolism across a broader area and sometimes producing those systemic effects. In other words, TMS is more about being precise and localized network activation, where PBM supports global energy and recovery processes. The third way they differ would be in their type of effect. So, because TMS is triggering those neural firings, it's known for modulating excitability. So, increasing or decreasing the activity in those areas depending on the frequency of the pulses and how you're using it. PBM doesn't necessarily push neurons to fire. Instead, it enhances their resilience and energy efficiency, helping them perform better under stimulation. So you can think of you can think of TMS as adjusting the brain's volume knob, where PBM is improving that speaker quality. And one of the last ways would be the biological pathway. TMS influences brain chemistry, things like serotonin, dopamine, and GABA release by changing how the neurons communicate with each other. PBM influences cellular chemistry and increases, again, ATP. It reduces oxidative stress and releases nitric oxide for better blood flow. One operates at the neurotransmitter level, the other at the mitochondrial level. Both are very important, but both are very different. And the last would be the therapeutic focus. So clinically, TMS is used to reactivate underperforming brain regions, waking up circuits involved in depression, OCD, addiction. PBM is more used for repair and support, so improving cellular energy in conditions like brain injury, cognitive decline, or inflammation. You could say that TMS, pushes the system into action, where PBM helps the system sustain and recover. So when we look at them together, TMS is electrical, stimulating neurons. PBM is more biological, fueling those neurons to work more efficiently. So combining them means that activating the brain and we're giving it the energy to sustain that activation. So it's a very true top down and bottom up synergy. So we're targeting things from both ends. So why would we combine the two? So TMS engages cortical networks from the top down, creating neuroplastic changes through repeated firing and synaptic modulation, where PBM supports those same neurons from the bottom up, boosting ATP, circulation, reducing oxidative stress, as I've said before. When they're used together, the brain is both energized and engaged. The metabolic foundation is strengthened while the functional circuits are being retrained. Theoretically, this could mean faster adaptation, longer lasting effects, and even potentially lower TMS intensities needed to release that threshold. So, a lower intensity would make the treatment more comfortable. And we're already seeing evidence for this combination in certain conditions like tinnitus, PTSD, cognitive impairment, and I'm going to walk you through a couple of those studies now. So, combining these modalities, it's still a relatively new idea in clinical practice. Until recently, research on neuromodulation tends to stay in its little silos, so magnetic, electrical, or optical, and they don't seem to mix too much frequently in research. But now studies are starting to bridge those fields. We're seeing early and promising data that PBM can modulate cortical excitability, and when it's paired with TMS, the two may amplify one another's effects. Let's look at a few of those studies that have explored this intersection, starting with work on cortical excitability, and then we'll move through tinnitus, PTSD, and again, cognitive impairment. So the first study I'll touch on is I'm gonna have a very hard time saying the names of these, but Konstantinovich et al. 2013. I know I said that incorrect, but this study asked a simple question, but a foundational question. So, can PBM actually change cortical excitability, which is the same property that we used in TMS? Again, I talked about the motor threshold. It's all determined on cortical excitability. So, in this study, they used TMS over the left motor cortex to establish that baseline motor threshold. Again, very standard. This is a standard TMS process. And then what they did is they applied near infrared PBM to the same region and surrounding sites. So, as you can see in that little bottom right picture there, that would be the sites that it was applied to. When they retested the motor threshold, they found that it had increased, meaning that cortical excitability had decreased. So the cortical excitability went down after PBM for about 30 minutes post stimulation. So, in other words, PBM can temporarily make neurons less likely to fire, suggesting that it can regulate excitability rather than simply increasing it. I think that's important because it shows that PBM isn't just energizing tissues, it's also capable of fine tuning cortical reactivity, potentially stabilizing overactive regions or priming them for more controlled stimulation, such as TMS. One of the main issues with using TMS with people with major head trauma is that you can't get that cortical reaction, or it would take just adjusting the machine's intensity almost to the maximum level, which at that point I would question safety. And we just still, for some reason, with major head trauma, we just can't see those motor reactions. And so it seems to be something with the cortical excitability So when I was looking at this study, I thought, I'm like, okay, PBM could be a great way where we could actually maybe begin to use TMS with people with major head trauma. If we could use PBM first, maybe lower their cortical excitability, maybe it would make it a bit easier to get reactions. I'm not sure. I don't think anybody's tested this, but that's the first thing that came to mind for me. Next, we're going to talk about a study which is by Thabit et al., and that is in 2015. And so this one looks at PBM and TMS in a more clinical context relating to chronic tinnitus. So they compared four groups. They compared TMS alone, PBM alone, and then they combined TMS and PBM in another group, and then they also had a sham treatment. So in this study, they used TMS to target the left temporal parietal cortex, where PBM was delivered to the ocular acupuncture points associated with hearing, so central and peripheral. Each treatment produced pretty small benefits on its own, but the combination yielded significantly greater reductions in the tinnitus severity on the tinnitus handicapped index. So as you can see here in the graphs on the right there, you can see again a huge decrease at the very left there with the combination treatment. And we do want the tinnitus handicap index, we want the scores to go down because it means that the tinnitus is bothering the client less. So you can see there were some reductions a little bit within the other two groups, but the reductions were major in the combination group. It's fascinating to hear that these two modalities were also pulsed at low frequencies. So it was 1 hertz for the TMS, which is a little bit more inhibitory than excitatory. So if you're pulsing at like 40 hertz, something like that. And the PBM was pulsed at 5 hertz. So again, both very low frequencies, and yet they still interacted synergistically. So to me, this suggests that pairing magnetic and light stimulation can create network level reinforcement. So TMS can reorganize those cortical processing areas where PBM supports the metabolic resilience of those circuits. So I think of this as maybe TMS is going in there and making those changes, and PBM is helping the brain to keep those changes long term. And so, even potentially, maybe with the combinations of treatment, one idea I had is that maybe in the future, there won't need to be so many TMS changes, TMS sessions to see long term changes. That's one of the things is that clients usually come in for 20 or 30 sessions. Maybe if you combine these two modalities, maybe they wouldn't need quite that many sessions to notice long lasting changes. Just an idea. I don't think that's been tested quite yet. And let's fast forward a little bit more into the future. So let's go to 2024, where Majan et al. Focused on a case study which explores personalized TMS. So this is, we refer to it as PR TMS, combining TPBM in a patient with co-occurring TBI and PTSD. So personalized TMS, it's still the same thing. You're doing TMS. It would just be the areas targeted are a little bit different. So some clinics will take an EEG or QEEG and look at the specific different sites and they'll stimulate specific different sites. Whereas TMS regularly, it has a standard site. So if somebody's coming in for depression, we would stimulate more of their F3 area. OCD, we would want to get those anterior cingulate cortexes, where personalized TMS, again, they would look at an EEG and make a personalized protocol. I haven't seen too many clinics doing this, but it does seem to be a little bit getting a little bit more popular. So PRTMS uses those EEG kind of guided targeting, and in this study, they used it at CZ, FZ, F3, F4, and they did 10 hertz over 5 weeks. After that 5 weeks, PBM was added to the frontal midline, so around the FPZ area, using a 10 hertz pulsing. The participant had already showed gains from just that TMS treatment alone for those 5 weeks, but once PBM was introduced, improvements in mood, sleep, and cognitive focus accelerated. The author proposed that PBM enhance the cortical responsiveness by improving regional metabolism, essentially making the TMS take more efficiently. For clinicians, this kind of hints at introducing PBM mid-course could also potentiate neuroplastic consolidation even after the repetitive TMS. And so if we look at this graph here on the side, you can see that the scores lowered a lot, especially when we're looking at the NSI, the BCL5. That little orange color is when TMS or when PBM was introduced. The blue color would be right before the treatment. And then you can see the green is in the final week. So a lot more accelerated changes after PBM was introduced. And finally, I think this is the most robust data set that we have so far, which was done by Han et al. In 2025, so a very recent study. And it was conducted with a randomized single-blind trial that had 86 participants with mild cognitive impairment. So this was the study that got me really excited about the idea of PBM and TMS. Of course, there's those other studies I talked about that show some promising data, but this one to me is very exciting. So they used a 2 by 2 design. So they did TMS and a sham PBM. They did a sham TMS and real PBM. And then they did the active part, so TMS and PBM together, no sham. And then they did one group with a sham TMS and sham PBM. So there's 4 different groups, and they made sure to use all of those sham situations to really validate the results. So the stimulation targeted the left dorsolateral prefrontal cortex with TMS, which was at 10 hertz, 80% of the motor threshold, and PBM was administered at 1064 nanometers for about 18 minutes in a continuous wave. So they used a lot of measures. So very commonly the MoCA for mild cognitive impairment, that's used a lot, the mini mental state exam, geriatric depression scale, and they also did some working memory tasks, just different things on a computer. So clicking on new appearing icons, connecting sequences of digits and end-back tasks. And so here is, I just really liked this picture because for me, it helped me understand really what those different groups are. So you can see at the top there, we've got group A, group B, group C, and group D, and it would show you how the treatment would go. So they would do the cognitive states and the cognitive tasks, then they would do the treatments, and then they would do a relax period, and then they would again go back to those cognitive states. Down below here, you can see the different tasks that were used, and you can also see a picture of how the treatment was administered. So they were administered together. If they were receiving active treatments or even the sham ones, that's what it would look like. So to me, the results were pretty striking. So the combined group, so the group that did TMS and PBM together, showed the greatest improvements on the MoCA, the MMSE, and the working memory tasks, along with an fMRI evidence. And this showed increased functional connectivity between the bilateral prefrontal regions. So they also did do fMRI tests after the study. Interestingly, the cortical blood flow also increased in sensory related areas. So, to me, this hints at a broader network engagement beyond just that stimulation area, even though PBM and TMS were very specifically focused on those frontal areas. It did show that blood flow was increasing in more sensory related areas towards the back of the head. And I think this study gives us the first controlled evidence that combining TMS and PBM, it doesn't just add effects, it amplifies it through these complementary pathways. And so there was, of course, some improvements in the other groups. So groups just doing TMS, just doing PBM, but significantly more in the combination group, as I'll kind of show here. So these are the ones showing the different results. I know they're pretty intimidating photos, but you can see, especially in figure A here, how the different scores changed, and as well as in figure B. So you can see that there was a lot of upward increases in the TMS and TPBM group. And then you can also see some of the neuroimaging on the right side here. So putting this all together, PBM can modulate cortical excitability, sometimes dampening and sometimes normalizing it, which means that we can fine-tune TMS effects. Across the studies we just reviewed, whether it's in tinnitus, PTSD, cognitive decline, the pattern's pretty consistent. The combination produces stronger and more durable changes than either of these modalities alone. So we're seeing a synergy, not an overlap necessarily, but two complementary interventions interventions acting on the same networks just from different angles. Again, that kind of top down and that bottom up analogy there. Magnetic induction can drive the activity, whereas photonic energy can sustain the activity. So we're actually seeing them work hand in hand. And I think it's pretty promising to show how we can be using interventions together. It doesn't always need to be one or the other. Sometimes the combination of using multiple interventions can actually be what produces the best results and really makes differences in clients' lives. And so that is it for me. Thank you so much for listening to me talk for the last half an hour.
Thank you, Alyssa. That was really helpful that just sharing your insights and distilling the current research on PBM and TMS so clearly. We do have a couple questions in the chat. Let me grab those real quick. Paige is asking, how is this different from neurofeedback? And is it better for training out spasticity?
Yeah, so it's a little bit different than neurofeedback in the part. So this is, I'm not sure how clinically accurate this is, but when I was working in the clinic, a lot of people would often ask me this as well. So neurofeedback is a bit more passive, right? We're giving people something on a screen. We're using those electrodes to read their brain activity, their brain waves. Based on that, we're changing the screen. So it's a lot more passive in the sense that we're not stimulating anything directly. Of course, I know there's a lot of different forms of neurofeedback as well, and I'm sure it can change too. I know there's a little bit more active forms, but at least the clinic I used, we used a very, I call it just like a bit more passive than compared to something like TMS, whereas TMS is actively giving stimulation and activating those networks. Again, neurofeedback, we're just like reading the brain waves and like trying to get the brain to operate on its own. With my, I guess, alarm clock analogy, we're just trying to positively reinforce the brain once it wakes up on its own. So if it wakes up early in the morning, we're giving it a high five, a good job, and a little treat. But with TMS, we're setting that alarm clock, we're getting up no matter what. And so it's just a little bit more, I'm not sure if intense is the right word, but a little bit more active. And for the second part of your question, I'm not 100% sure. So I don't want to answer. I'm not sure.
Perfect. There's one other question, or no, this is just a comment. The Heinz VA in Chicago has used TMS for veterans that have had severe depression.
Yeah. It's super commonly used. I'm even seeing things like just on my personal social media, I'm seeing a lot of people use TMS, especially for depression. I would say 90% of the clients I saw, it was all for depression, if not more than that. Even though it was off label, I did see a lot of success for PTSD as well. Other than depression, that's where I saw a lot of changes in clients. So the clients coming in for things like PTSD. So I'm still, honestly, I'm not sure why it's still off label. Just like seeing how much success I saw with clients, I'm shocked that the protocol for PTSD has not been approved. But of course, there's off-label things, and even when we talk about personalized TMS, that would all quote unquote be off-label because you're making up your own protocols based on the brain activity. But yeah, it's very popular for depression these days. I get ads on my Instagram all the time for different TMS clinics. It's for me, it's exciting to see it be more popular, especially just when I saw its success with my own clients.
I want to make a comment. My name is Mark Halverson. Dr. DRC knows who I am, and of
Yeah,
course, Chris Garvin does too. I'm an affiliate, I'm a promoter of Neuronic
yeah.
for TBI survivors,
Mhm.
and I love it. I was in Chicago at the ACRM conference last week, and I'm surprised I didn't see any of you folks there. I think you being there, because brain injury is a big part of what we do at American Congress for Rehabilitation Medicine. And there's just so much evidence out there in photobiomodulation and of course TMS. And it's really starting a lot with veterans. But are you guys looking to take these technologies and work them together, get them out into clinics to help people recover as best they can after from PTSD depression standpoint, but also from a just a brain fog, cognitive part, because there's just a lot of great work there.
Yeah, we do work with quite a bit of different clinics that kind of, like your situation and like you described, that are using it with different populations, different modalities, a lot of clinics, as a question that I think Paige asked. There's a lot of people using PBM. Of course, all day I've been saying TMS and PBM, getting them mixed up. But PBM and neurofeedback, that's really popular. A lot of places will do PBM before they do neurofeedback. And very similar to what I presented on TMS, sometimes they find that it can help sustain those changes, just prime the brain to make those changes and sustain them long term.
Yeah.
So we do work with a ton of clinics. We do go to a lot of events. Obviously, not every single event. Coming from a small team, sometimes the coordinating's hard, different things like that. But yeah, we love speaking with clinics. We love hearing people tell us how they're using the device and what kind of modalities they're integrating it with. Especially PBM, I think it's a pretty new science relative to some of the other modulation techniques that have been around in the world a lot longer. And so we love working pretty closely with different clinics. And I don't know, just hearing about everybody's experience and also just hearing suggestions, improvements that we can make too.
Yeah, you may want to write a paper, have a paper put into the archives of ACRM, because there's just a lot of evidence-based
Mhm.
material that is evolving, right? In cognitive
Yeah.
improvement and brain injury and PTSD, of course, too,
Yeah.
depression. So I just think that would be really great.
Yeah. Yeah, for sure. I know that we're working. I don't have them off the top of my head, but I know that we've got a lot of active studies going on right
Good.
now with
Good.
different universities, things like that. So you should see our name. Obviously, it takes quite a while to get things published and going. Anyone that
Oh,
works
I
in the
got
field
it.
knows how much of a pain in the butt it is, but you'll see it there eventually.
Thanks, Mark. John McCroot made a great comment. TMS is a space heater and neurofeedback
Mhm.
trains to operate the thermostat. I like that analogy.
Exactly. That's a great analogy of saying it. So you still need the heat, but you also need that thermostat to see what the heat's at.
Can I just make a quick comment? Is it Mark?
Yeah,
Yeah, Mark, nice to meet you.
nice to meet you, John.
Please encourage your people in the brain injury recovery business to think about neurofeedback more. I'll speak bluntly here. I am prejudiced against TMS, a lot of reasons. I can't for the life of me understand the learning curve involved in TMS. I understand its use case for dramatic intervention, but over as a long-term strategy, I don't think it's valuable. And I think the data probably bears that out. The effects of TMS wane rather rapidly because there is no inherent learning curve to it. You're telling the brain what to do, and it'll respond, of course, but it doesn't retain that learning because it's not self-engaged. That's what neurofeedback will provide. We work with stroke victims, all kinds of folks who have had serious brain injuries, concussion, all of that. Neurofeedback is a much better answer than TMS. I'm going to be, again, blunt. Not to just, and by the way, Alyssa, to
No.
understand, just for you to know, I think this is very valuable for the community to understand all of the different aspects and where they can fit in. I'm a huge believer in PBM. And I use this in our clinic. And the issue with PBM very specifically is you have to dig a little bit deeper to make sure that the person receiving stimulation like PBM have the resources nutritionally, let's go deep, hormonally, to make sure that the mitochondria will respond. You can overstimulate somebody with something as I view as benign as PBM.
Yeah.
So it's a very complicated, multi-layered structure that we're talking about here. But
Yeah.
brain injury recovery is a passion for a lot of neurofeedback providers. There are people who specifically, their clinics specifically are designed for it. Mine is not, but I've had my share. So I would encourage, Mark, your people to really dig into the neurofeedback solution. It's not as appealing. The appeal of TMS is it's quick, it
Yeah.
feels like something's happening. So there's a validation for it. It's
Yeah.
covered by insurance.
Yeah.
That's a huge one.
Yeah.
Yeah.
So I've seen people do 80, 100 sessions of TMS with not particularly good results. They're
Mhm.
okay, and there are side effects, let's be honest.
Yeah.
There are any known side effects to neurofeedback. It's a
Mhm.
learning paradigm. It's completely the opposite of a stimulation. I see Patricia nodding. It's a completely different paradigm. And that is difficult for consumers to grasp sometimes,
Yeah.
Oh,
especially
yeah.
somebody who's
Yeah.
struggling with a brain injury. I just want relief, please God, anything.
Yeah.
Some combination perhaps of the three.
Yeah.
Yeah. John, I put my phone number in there. Go ahead and text me and let's set up a call, because Paige is on there. Paige and I were at ACRM in Chicago. Paige is in Missouri, and she struggles a little differently as she articulates a little bit with spasticity and such. But the point I guess I'm getting at is that I have studied the photobiomodulation and the neuronic glow, and I was even involved with the NeuroCatch EEG, because let's measure what we're going to treat. We got to know we got to measure first, but there's so much good stuff coming out. And traumatic brain injury, from a cognitive standpoint, takes time. There are exercises, there are neuroplasticity exercises And in my support group, we do a lot of these. So getting this information in this panel today, Alyssa, has been great. You are passionate and you only have your undergraduate right now. Is that it? Oh
As of
my,
right now,
oh my
hopefully in 8 months.
I
God.
know
Hopefully 8 months.
she is scary smart.
You are, I just love that because that just tells you the potential you have and the potential the industry is going to have when somebody as passionate as you. I'm a lived experience guy. I've made a full recovery.
Yeah.
I'm 26 years post, and Brooke has met me before because I've been on with Dr. DRC and of course Nicole knows me. I brought Nicole
Yeah.
Gregg into my group and Chris Garvin, but my God, this is good stuff, right?
Yeah. And there's so many modalities. It's every single day some new research comes out. Like even
Nice.
what spurred this presentation, I was like, wow, okay, people are doing research on combining TMS and PBM.
I
Yeah.
had 8 months of twice weekly neurofeedback in 2016 and 2017 in my first year post oxygen deprivation brain injury. And that at least set the foundation where better nutrition could pick up from there and put my anxiety into permanent remission without the pharmaceuticals.
Yeah. And like you said there, nutrition's a huge part of it too. I think that the brain is so complex that sometimes I don't always think that one specific intervention can quote unquote fix anything. It's targeting all of these areas. For example, like working at the clinic, we would do a lot of times similar, John, we would do like all of these interventions on everyone. So sometimes it's hard to notice like which specific intervention the client says they're feeling great. Which one is it? Is it maybe because we're doing all three together that makes it work? Is it I'm like, we would also talk to these people pretty closely. If one of my clients is telling me that they're just sitting in their basement playing video games all day, hey, probably not going to help you feel that much better. You know what? Next time you come in, I'm going to ask how much time out you got outside. Okay. Give me 5 minutes. You could stand outside in the sun for 5 minutes. That's all I want from you. And so there's so many dimensions and it can be so hard to know where to start. Or I think it's again just taking in the unique client and see what they're lacking. Are they not eating well? That's the whole foundation to your brain health. Are they not sleeping? Well, that's also a really big part of it. So it can be there's so many different modalities and it's all about finding what works best for the client. But I do agree a little bit with what you said, John, about neuromodulation. It's teaching or neurofeedback, sorry. It's teaching the brain to rather than doing it for the brain. And yeah, the appeal of TMS is it is fast. It's 20 sessions, whereas neurofeedback can take months and months and multiple sessions. And of course, it depends on the client. Some people respond very quickly, but I found with neurofeedback, the responses were a little bit slow. Practically, it's hard to I found it very hard to encourage people to keep going after these people are there because they're suffering in some aspect, right? They're struggling, and it's hard to encourage them without that quick results.
Respectfully, I think we need to help clients frame
Yeah.
this properly for themselves. This is
Yeah.
a self-regulation, self-empowerment training. That's what neurofeedback is.
Yeah.
Stimulation is not. It's
Yeah.
as clear as that. You'll get some momentary relief. It's not going to last because your brain hasn't learned anything. So if you frame it in, do you want immediate relief or do you want long-term relief? If you want immediate relief, take Prozac.
Yeah.
That's a simple
Yeah.
answer. To take a medication. There's hundreds
Yeah.
of them available. They
Yeah.
will not fix your problem. Your
Yeah.
problem is in your brain circuit wiring and it needs to be remediated. And there's literally only one way to do that: neurofeedback. Sorry, I've got some blonde guys out here.
No, all good. Patricia, feel free to pipe in there.
Basically, but I'm a long-term neurofeedback therapist. Basically, it looks passive, Alyssa. It's not passive. Basically, because what you're doing
Yeah.
is when the brain waves reach the aggregation of what you want in brain waves, then you get a beep. And that's
Yeah.
stimulation for the brain, and that's
Yeah.
moment. And those aggregate to
Yeah.
usually you can get some finite results with
Yeah.
feedback for whatever. It took 40 to 80 sessions to help a person with ADHD. It took me 40 to 80 sessions to help a person with migraine. And then they
Yeah.
had none, and it lasted. Okay.
Yeah.
So that the one thing I found about PBM, and I love it, and I've been using it for 8 years, is that the brain has to have continued stimulation. And it's the stimulation that helps you feel good and gets it helps my memory, recall, and stuff like that. So I'll be using it until I can't use it anymore. But neurofeedback, I've had hundreds of my own sessions, but it is a learning, as John says, it's a learning paradigm. It's a conditioning
Right.
of the brain.
Yeah.
And so that the brain waves then act in concert with one another in a way which is beneficial.
You brought up a really interesting point, Patricia, and thank you for saying it that way. Neurofeedback is not passive at all.
No, it's
It's
not.
entirely active. I would argue TMS is passive.
Yeah.
Yes, I agree with you.
You are the recipient of a treatment.
Yeah.
In neurofeedback, you are a participant in a training.
Your brain is.
And your brain,
Yeah.
exactly. Yeah, yes, unfortunately for the
It
person,
doesn't, it
they
doesn't
Yeah.
actually have to bring their brain,
that it lets the brain do the work.
that's right. They have to bring the brain to the office, other than
That's
that.
right. That's
Yeah.
right.
It's a bit more, subconscious, unconscious, which I'm not sure the exact form of neurofeedback you guys use, but I've seen lots of clinics use lots of different forms. In the clinic I would work at, we would use a lot of visual and auditory stimulation. So we would put movies on the
Alyssa,
screen.
You have to have, I think you have to have auditory for the auditory.
Yeah.
It's got to be that. That's absolutely crucial. So I've
Yeah.
never worked with a deaf client, but I would only have to be able to
Yeah.
use visual, or
Mhm.
if you had one who, first, I've never had anybody who had both, but you could use tactile. So there
Mhm.
is a way to get to the
Yeah.
sensory experience
Yeah.
that you can modulate.
Yeah.
I think the
Do you use
Optimers might argue with you, Patricia.
Oh, they might? Why?
They use primarily visual.
Oh, do they really?
Yeah,
I'm
Alyssa, I am so sorry for hijacking your meeting.
No, I'm very curious. I wonder what kind do you use auditory and visual, John? Or I've heard
Yeah.
a lot of places
Well,
just doing the auditory
We have a
too.
combination. We use infralow
Yeah.
frequency, which is
Yeah.
largely visual feedback.
Yeah.
And we use traditional band training, which is
Yeah.
biased towards auditory feedback. So we use it
Yeah.
all. And you're right,
Yeah.
if somebody is blind, we have obviously haptic options,
Yeah.
buzzers and things like that.
Yeah.
There's workarounds for all of that.
Yeah. Yeah. I never thought about that.
I don't know if anybody on this call is a TMS practitioner, and I apologize if I sounded arrogant and condescending, but I guess I am.
You're entitled to your bias, John.
I don't think so. I think it comes from your experience too. You're not just saying things to say things,
Right
John.
on, no doubt about it.
It's experience. I've had more than 25 years of experience as a neuromodulation person, a neurotherapist. I rarely use just biofeedback tools
Yeah.
that I teach people rhythmic breathing, but that's about the only biofeedback kind of thing that I use. But other than that, the neurofeedback has been phenomenal. I've had 99% reduction in migraine in my practice over 25 years. That's getting people off of medications that
Yeah.
have rebound effects.
Yeah.
So that to me is just incredible. But
Yeah.
whatever, it's not embraced by the medical profession, maybe because it's passive, because they think the way you do, that they think it's passive. And there are a lot of people that do not understand behavior theory, period.
Yeah.
There are a lot of physicians that do not agree with it and do not use it. I'm a behavior theorist.
Yeah, but Alyssa, let me just bring up this point, and I just want to say, when I first heard about TMS, I heard it from myself being a veteran,
Yeah.
and it was at the Heinz VA, and it was the bottom line, they were focused on depression. Now, I'm
Yeah.
going to tell you, I'm a 26-year survivor of a TBI, and I have never been depressed. I've been put on SSRIs to treat depression, but all they did is they just slowed me down. Obviously, needed more serotonin than I had. My point is, depression, anxiety is a big deal, but depression. So when we go into photobiomodulation or the neuronic and the glow, I think that's excellent in the sense that you're working it, you're working your brain, and it's not passive. I think with TMS, there's a lot of people that is beneficial, okay? Because you go back to the depression. Now, if neurofeedback, John, has done a lot of work with the depressed soul, be it a veteran or civilian, that's good too. But I just like the fact that these modalities are all coming together in a sync way, that there are solutions, right? There are areas of growth and recovery for people that have had brain injuries. Yeah.
Yeah. I think that's a good point too. It can be used in conjunction. With TMS, the one big thing in our training was that there was an option for maintenance. So I also think that indicates that some people don't see, they get this momentum, but maybe it peters out a bit. I had some clients come back for maintenance. I was only there for a few years, so I'm not too sure how my clients are doing now, but I think sometimes it can be the combination too. Like maybe people need that big push with TMS or just that big motivation when you see immediate results. Sometimes it's, I think about it like with the gym. When you go to the
Yeah.
gym for a week and then you like look at yourself in the mirror and you're like, okay, my biceps actually do look a little bit bigger. Like I can feel it a bit. It makes me want to keep going too. So
Right.
sometimes I think, especially with depression, which is really complicated. And personally, I think there's a lot of reasons for it. Again, let's talk about nutrition. Let's talk about habits as well. I think there's a lot of things that can be the underlying cause, let's say, sleeping issues, things like that. It's not always, I just think there's just so much that goes into it. And I think I always think the combination. Like, I think in practice, I think in the clinic I was working at, we would rarely use one modality for a person. We would often combine a lot of things because I just think they can all work together. Again, like PBM neurofeedback, that's one that we hear a lot about. I don't know. I just think there's so many things that can work together. And yeah, like maybe TMS can get some things activated, get some systems going, be a kick in the butt, and then neurofeedback can come in and like really take advantage of that energy and really let's learn, let's make these big changes, things like that. And I see your question there, Roger. So is there a way to access TMS with a QEEG and not ineffective antidepressants? Yes. I would typically have a lot of people, I'm trying to recall now, I can't remember the exacts, but I think a lot of my clients weren't necessarily on antidepressants, or if they were, the main goal was to wean off. But yes, you can use a QEEG with TMS. I talked about that personalized TMS. So there's some clinics. I'm from Canada, so I know that there's a big clinic up in Alberta that's doing this with children with autism. And so they'll use a QEEG, look at the different brain areas, look at the activity. I haven't done this myself personally, so I'm not exactly sure what goes into this, but they would make a personalized protocol for these clients based off of a QEEG. So they would maybe stimulate, very typically with depression, TMS, it's F3 area, but they would stimulate all over the brain, different parts, different frequencies, and that would all be guided by a QEEG. I'm not sure exactly how they would do it or exactly like how they make those decisions. It was something I noticed, but I was a little bit hesitant on just because it seems to be a little bit newer. But
Right,
you can
thanks.
definitely use a QEEG.
Yeah. I've had trouble even getting an answer from the local clinics here to get past the basically two failures on antidepressants. And I've just got
Yeah.
no information at all. So thanks for the answer. I'll keep pressing.
Of course, no problem. And yeah, each different clinics operate differently, have their
Right.
own procedures, whatever, etc. It could get, I guess, political if you want to say, but I guess it's a business at the end of the day. But no, we wouldn't always necessarily, like, you wouldn't have to necessarily be on an antidepressant or have tried one and failed to receive TMS. I know some people will do that, but I think the main goal at the end of the day, at least that I saw, is people don't want to be reliant on medications for the rest of
Right.
their life. There are some pretty wicked side effects. And then also, again, if you're not addressing that underlying issue, you're not going to solve the problem at the end of the day. For some people, it works great. I've heard people that use antidepressants say it changed their life. They stop and they're great. I feel like that's more rare though.
I was not aware that anyone was using TMS for autism, especially on children.
Yeah.
It's not authorized for that use.
Yeah. No, it would completely be, that would be completely off the label.
I'm
Yeah.
shocked.
Yeah.
I have a daughter on
Yeah.
the spectrum, so I'm
Yeah.
very sensitive to this.
Yeah.
I am stunned that
Yeah.
somebody would do this on a child
Yeah.
for any.
I agree with you 100%.
I know you
Like
do.
we would not use, especially children, like thinking about, I think with TMS, it's important for the brain to be fully developed as well, just because it can be quite intense. And then also think about the sensory. Like it does feel, seriously, like TMS, it feels like somebody, there's a funny bone inside your brain and someone's hitting it. Like it doesn't, I would not say I particularly enjoy the feeling. I've had clients say they like it, and I'm always like, are you okay? Are you, we need to talk to somebody. Like it's not super pleasant. And so I cannot imagine how they would get a child, let alone a child with autism, to sit down. You can't move, go through that. Like it is I can't imagine how you do it other than having to hold the child down, and I don't agree with that at all. So yeah, I don't think it would be. I haven't personally really used seen TMS, at least in my experience, used for autism, but I know some clinics would. But yeah, it's not my cup of tea. I'm sure people have arguments for using it, but not sure what they would possibly be.
Oh,
Um,
Rush, he just put another question. Do we know what the indicators are from the QEG for TMS?
I'm not exactly sure. I just don't have any experience using the QEG directly with TMS. If we had clients doing, let's say, neurofeedback in TMS, of course, we need the QEG to help with their neurofeedback. We could see some changes, especially in the frontal area, but also they were doing neurofeedback as well. So it's hard to exactly say which exact changes are from which modality. I think I don't think we ever did used QEGs with clients that were just doing TMS. Typically, it's not required. Like if you're just doing TMS, most places wouldn't do a QEEG, which I think is more of a logistical issue personally, but especially in the training, like we had all these companies that use those TMS devices, they'd fly out, they would do training with us. Never once was a QEG, the word QEG even uttered in those types of trainings, which is again, I think it's some of the best it's one of the best measurements tools that you can have. And so it's not explored as well, especially only in those like personalized TMS, which again is also completely off label. It gets pretty complicated.
This is so shocking to me, this conversation. The fact that somebody would apply an energy to a human brain without a map is
Yeah.
unbelievable to me.
Yeah.
Source analysis, ICA source analysis, for God's sakes. It's not that complicated, or by the way, expensive. It's not
Yeah.
that bad.
No.
Oh, I have to go now.
Especially with things as like epileptiform activity. So again, like one of those things being that like seizure, you do not want to use such an intense stimulation with somebody with a seizure disorder. Especially if we're talking about kids, especially with children, like things like absence seizures. A lot of times if kids are having seizures, people don't notice because it's not like in the movies where you're always on the ground like convulsing, right?
60% of autistic spectrum children have epileptiform
Yeah.
discharges.
Yeah.
Why would anybody attempt to put electrical energy into a brain with that
Yeah.
already threshold provoked? I don't even
Yeah.
have ADD, same thing, about 50.
Yeah. Exactly. So I think there's a lot of gaps in the field as well. Even when just talking about the field of modulation, neuromodulation, I think that somebody touched on it, the insurance point of if something's covered by insurance, more people are going to go for it. It's pretty unfortunate, but even me personally, I'm like, I can't afford to go do like 100 sessions of neurofeedback right now. And a lot of people can't. A lot of people, I live in Vancouver, so like one of the
I'm
most
down to
expensive
Los
cities.
Angeles. I'll help you out. Don't worry about it.
All right,
But
guys, I'm sorry we have reached our time. It is just past a few minutes over. I'm really sorry, but thank you, Alyssa, and thank you everyone for joining today. And before we go next month on December 4th, Ryan Field will discuss the development history of kernel and how they selected time domain functional near infrared spectroscopy to non-invasively measure the brain and apply technology to better understand cognitive function. So we hope to see you there, and thank you for joining us today, but thank you again, Alyssa.
no worries. Thanks for the
Thank
great
you.
discussions,
Yep.
guys.